Hello, everybody. Got it. Thank you, uh, team, Echo team. So today is not May 11th. It's would it be nice weather-wise, but it's November 28th. And we're just going to go through a very general overview of some developmental screening specifically for ADHD and autism spectrum disorder. Next slide. So we're going to go through what the developmental screenings are, kind of the role of the pediatrician. Like I said, we're going to take a look at ADHD, autism, and then finally the role that the school can play in any of these screenings and kind of the overall health of the child. Next screen. So for developmental screenings, you can go to the next slide. Around 2021, it says right there on the bottom, January 1st, 2021, LDH made sure that their screening guidelines matched with the American Academy of Pediatrics periodicity schedule. I can never say that word correctly. So that is really the 9, the 18, and the 30 months down there. And so what they want to do is make sure that all Medicaid insured children younger than the age of 21, Medicaid typically sees children as 21 and younger, they're covered, they have coverage under the early periodic screening, diagnostic, and treatment benefits. So what that means is they're covered for preventative, our well visits, developmental services, of course, our routine physical health, mental health, and developmental screenings. And then based on those developmental screenings, any evaluations further down the line that's needed for any illnesses, conditions, or disabilities. So that's going to include learning disabilities, anything like that, which we'll go over at length. And then through collaboration with LDH, AmeriHealth specifically, we have a $10 reimbursement for providers that provide this CPT code, specifically 9611, to incentivize our children, making sure they get these screenings done early, because we all know preventative and early screening will help prevent those later problems down the line, and their earlier detection, the better the outcome. Next slide. So some approved developmental screening tools, again, this is according to the American Academy of Pediatrics. The ages and stages questionnaire, which I think is the most common. I think it's the most common that I have seen, both professionally and personally, actually, when I bring my own children. And so we will spend some time on that in a minute. And then the communication and symbolic behavior scales, the developmental profile. Then the parents' evaluation of developmental status, and the parents' evaluation of developmental status and milestones, and the survey of well-being in young children. Now, there is a cost associated with these things, but it would not be at the cost of the parent. Typically, it's at the cost of the provider. So if I'm going to my pediatrician, they'll pay to have, the most updated versions of these assessment tools. And also if they're inputting anything into a database, they will pay for all of that information there. Next slide. So the ages and stages questionnaire. This is a long series of questions that the parent typically will fill out at each well visit. So for a baby, a newborn, you're going to fill it out. And then, the 3 months, the 6 months, each subsequent visit. And as you go on to the visits, there's more participation from that child. So obviously, I'm not going to ask, my 3-month-old, can they say their ABCs? But as you go on, I think, it's like the 5-year-olds, the 6-year-olds, hey, can you repeat these 5 sequences, red, black, yellow, green, and can they repeat all that? So those are the types of things they're checking throughout. Does your baby make eye contact? Does your toddler look at you when you say their name? Those types of questions. So they cover several domains, which I think we go over in a later slide, and it provides a scoring at the end. So based on the I think it's a Likert type scale, where you have sometimes, never, usually, often, seldom, and it has certain numbers associated with that response. there's a certain scoring at the end. So, you know, you don't have to spend a lot of time in the office answering questions. The pediatrician can quickly look at your answers and get a good idea of what's going on just based on that data and numbers. The most updated version is the ASQ3. It's administered, like I said, for every well visit, ages 1 month to 5.5 years. And it covers physical milestones. You know, can they grab on something and hold it? If you give them something to hold, do they curl up and hold on to it? Can your toddler, you know, throw a ball? Those types of questions. You know, can the baby pull themselves up on their own feet? So they're checking on all these physical milestones, behavioral cues, speech and language, and social development. Even as a baby, you know, there's questions. Does your child look at themselves in a mirror? You know, do they smile at their reflection? Those types of questions. So it's really a very comprehensive way to look at each domain in a way that a parent can pretty easily identify. You know, they're very like vernacular friendly language. There's not a lot of jargon, and the input mostly comes from the parent. There's the website there. I believe they have most of them listed for the different stages and ages. I also believe I include a link at the end. Next slide. And so as you go to your pediatrician and you're filling out the ASQ3, it checks on vision, it checks on hearing, the responsiveness to the caregiver. So do they smile when you walk in a room? The responsiveness to the environment, responding to sounds and stimuli around. They ask all these types of questions. The social skills, awareness of environment, others, and self. Physical strength, like I said, they ask a lot of grabbing questions for the newborns. And as they go on, you know, can they pull themselves up? Can they walk? Those types of things. And then problem solving and cognition. Those are really important throughout the ASQ. And you'll see, if you're familiar with the ASQ, how it progresses appropriate to each age. And like I said, they are designed to be parent-centric, which will also give the pediatrician cues regarding caregiver involvement, temperament, and relationship. So if I really don't know a lot of the answers, you know, that might cue the pediatrician in on some things. If I sound very stressed out, if I, you know, I can't fill this out, you know, it gives the pediatrician some information about the parent. I know in the last year or so, a discussion regarding pediatricians and checking in specifically on mothers of newborns and mothers, even if it's not their first child. You know, what is the pediatrician's responsibility to check on the parent's depression, the parent's ability to cope, the parent's managing of a child, whether they have 1 or 7. My sister has 7. I'm worried about her sometimes. So you really want to check in with the parent. And I think that's a growing area for some pediatricians and their practices is checking on the parent, which I wholeheartedly agree with. But the ASQ is also designed to help the parent as well to see what kind of things they should be looking out for. Next slide. So the pediatrician is also going to monitor the diet and eating habit of the child. I remember the very impossible question, you know, if you're breastfeeding your newborn and the doctor's like, so how much is your, you know, 3-week-old baby eating? And you're like, I don't know. So they ask you very impossible questions about the eating habits of newborns. Like, how are you supposed to answer that? I don't know. But they will continue, you know, are they drinking enough milk? Are they having formula? Did you switch to solid foods? How, you know, how are they doing with introducing new foods? How are they doing with solids? So your pediatrician is asking all of that, especially when they're younger and they see the doctor more often for those well visits, and they're having a lot of those firsts, you know, first steps, first time eating a solid, first time eating a vegetable, you know, having pureed versus the actual food cut up. So they're monitoring all of that, and they're probably looking for the overly fussing eating habits. You know, does the parent just need help with, you know, the baby's hungry, let them eat it, you know, let them get there. Or is the baby truly like overly fussy, not eating anything to the past the point of hunger? Does the baby have some texture preferences? Do they have difficulties with certain foods? So all of that is being screened by the pediatrician throughout, especially that first year of life. And so that's why we say the pediatrician is that first line of defense in terms of that early detection. And it doesn't mean that if your kid who is now 2 only wants chicken nuggets, that they have autism, right? So we're saying it just can alert to the possibility of a sensory disorder or autism. Those type of things with food isn't typically related to anything with ADHD. But you're just keeping it all in mind. That's why the ASQ is very comprehensive, and it's going to hit in all areas. And you'll see later when we get to the diagnosis criteria, you can't just have one area. You can't just like chicken nuggets and then be labeled as having autism. So it's just cueing the pediatrician in or cueing the parent in for maybe some further exploration. And then difficulty in sleeping, that's going to be related to ADHD. Now you're going to have things that are normal. Sometimes a baby will nap really well and then kind of regress and go in and out. Same thing, toddlers, a lot of times will get something called night terrors. They might have some difficulty adjusting to different nap schedules. But outside of those things, and memory retention, that should be monitored for ADHD. And so remember earlier when I said some of the older ASQ items, we'll talk about, hey, green apple, purple chair, red. Can that kid just repeat what you just said? And if they can't, that doesn't mean that they have ADHD. It's just like, oh, okay. Could they do something similar in the last appointment or in the next appointment? I can tell you right now, my son couldn't do it at all. My daughter, no problem. So, and neither one of them have ADHD. So it's not, again, a definitive. It's just things that you're looking for, like the slide says, just cues, things to make you be aware of what's going on. Next slide. So let's get into ADHD. Some people still call it ADD, but all types of attention deficit are going to fall also under this attention deficit hyperactive disorder. And there are 4 different types underneath it. So inattentive, hyperactive, impulsive, or combined. So they're all going to be considered ADHD. And you're going to specify which type it is. Next slide. So the DSM has specific criteria for each type, as well as how many symptoms need to be present. So you're going to have, like I was saying before, a slew of criteria. And the DSM will obviously, okay, they need this many from category A and this many from here and that many from there to really have a diagnosis, a true diagnosis of ADHD. And typically it is done before the age of 12. There is a process for adults that I am not as familiar with. And it's certainly to be, as we get to the teenage years, I think that introduces a lot of other factors that it has to do with puberty, and hormones and changes. And it would be difficult to separate that out from ADHD. And then going into full-blown adulthood, I'm not sure what that process is, but I would imagine it's a comprehensive history there. Because I hear a lot of people say, oh, I've been ADHD my whole life, but I've never been diagnosed. And I always, mentally, I'm like, well, because people think just because they have trouble paying attention or they move on to one thing and not another, that, oh, I have ADHD. It's similar, we use casually, oh yeah, OCD. I'm just OCD about that, but clinically speaking, that is not necessarily accurate. Just because you like all the dishes done every night before you go to bed doesn't mean you have OCD, which is a very debilitating disorder. So it's the same thing with ADHD. There are some criteria that need to be met typically before the age of 12. There are a lot of ADHD assessments. I highlight some here. We have the Vanderbilt ADHD, that's probably the most popular, the Child Behavior Checklist, kind of abbreviated symptoms, and you can read through those different highlights. They all use a Likert type scale. The key to getting a child diagnosed with ADHD is taking them to someone that's appropriate. If you have just LPC or LCSW in a private practice, that's never really been trained in doing an ADHD assessment, they could do it. But as a parent, would that be my comprehensive, that's it, you have ADHD? Probably not. There are several steps to really get that accurate diagnosis. These are just some of the assessments. But again, anyone can use an assessment. You really want to make sure you're going to someone trained in that, and many psychologists will specialize in many different types of assessments, including ADHD. Next slide. Yeah, so there are many valid assessments for ADHD, but there are components that are important in each one. So like I said before, you can't just not like chicken nuggets or only like chicken nuggets, excuse me, and be like, oh, I probably have autism because I don't like any texture of anything else. I'm sorry, we're talking about ADHD, my apologies. Because the deficiencies must be noted across domains, at least two. So school, home, social relationships, daily activities. So, excuse me. Across all those, there have to be troubles like at school and at home, or you're having a lot of trouble socially and at home. Typically, if there's just problems just at home, that's going to kind of clue you in onto something else. A lot of parents will say, my child is wild and they don't listen and they can't stay on task and they're really loud and they're all over the place. And that may be true, but then at school, they are very well behaved. They stay on task. They do their work that's at school, maybe not their homework, but their schoolwork. And that's typically a very common situation that you see in parents that are concerned somewhat about their child having ADHD. I need to see it across domains. I need to see, you know, in social relationships, are they very combative? Is it very emotional? Are they having trouble in school and at home, any daily activity? Can they never manage to brush their teeth while also going to the bathroom? Well, they always forget, but they're all over the place running around. So there has to be across domains different problems. And the best way to gain more than one viewpoint into an assessment, probably the parents, but probably the teachers. So if I'm a psychologist and little Susie Q is coming into my office for ADHD testing, you know, I'm getting the parent paperwork beforehand. Hey, give this to the child's school to fill out. Or if they come in and I do their assessment and they score pretty high, I might give the parent, hey, here are these forms. Can you take them to school, have the child fill out? You know, I might get a release of information, call the school and give them the forms myself electronically, whatever the system is. But you have to get feedback other than the parent. And we're not dogging on parents by any means, but kids will behave differently when their parents aren't around. My kids are perfect angels when I'm not around. So trust me, when my kids are in school, they're very well behaved. I have no one to blame but myself for their behavior at home. So you want to get, you know, a different outlook other than the parents' feedback to get that true ADHD diagnosis. Because a lot of times, and that's my next point, is environmental factors play a huge role. So you have domestic violence. Kids can witness domestic violence. They could be victims of abuse. They could be victims of any type of trauma, even something like a car accident. And those symptoms will be very similar to those ADHD symptoms. I was tempted to be like, you know, a lot of kids are diagnosed with ADHD when they have trauma, but I don't have that data here to support that. But I have run across, I should say, many children in my assessments over the years that are taking ADHD medication, but really they have some serious trauma and most of them some chronic trauma. And those symptoms are very difficult to separate ADHD and trauma symptoms and PTSD. So that's why it's really important to have that comprehensive assessment. So there are many assessments, but you need to hit these 3 points for it to really be accurate and comprehensive. Next slide. So age, we talked about this, about the older ones, but the younger ones. Most assessments are for kids that are older than 6. You think about a 4-year-old versus a 6-year-old, there's a big difference. A 3-year-old and a 5-year-old, there's a big difference. So ADHD is typically identified as a child enters the school system, right? So now we got more than one domain, we got more than one viewpoint, and the child is being told, maybe sometimes for the first time, to stay on task, to sit in the seat, to do these sometimes boring things, right? So can they stay on task? Most doctors, not all, you have some specialists, but most doctors are pretty hesitant to prescribe ADHD medication earlier than 6 for developmental reasons, but also just the differential diagnosis. They're young, so they have um, symptoms of being a child. That's their diagnosis. They're kids, so they can be difficult and crazy and all over the place. There are some approved medications for children as young as 3, but the recommendation typically is behavior therapy and a lot of focus on parenting. And again, we're not dogging on parents, but if your child really is that uncontrollable and all over the place, giving them medication at such an early age, well, sometimes may be necessary. You may be doing more damage than good. I mean, their brains are developing so quickly, their bodies are developing so quickly. So you really want to try to work with that parent about how to manage what's usually a behavior before you really want to get into those later interventions. So you're not saying that this kid definitely doesn't have ADHD. You're trying to say, well, for now, they're so young, let's work on these techniques before we introduce medicine or the possibility of medicine when they're 6 or older. And yes, young children are naturally very active, very curious, disorganized, very loud. Mine are very, very loud. Even when they're doing nothing, they're very loud. They have difficulty sitting still. One of the ways I know my child doesn't feel good or is sick or possibly has a fever is because they're very still and they're very quiet. And so that's usually, any parents are in here, you're like, yeah, because that's how you know they probably are sick, because they're still and they're quiet. So most kids aren't going to be still and quiet. It can be difficult to diagnose ADHD in a child younger than 6 due to these factors. Additionally, nutrition, parenting, environment, as we know, can play a role in young children's what we call wild behavior, but really they're just acting exactly like they should. Next slide, please. So we kind of touched on this. When you're considering assessment or even an assessor, who do I take to get this child assessed? Does that assessment include, and does that assessor, that person, include items and questions to rule out other diagnoses? We talked about PTSD, which is probably the most common. Sleep-wake disorders, a common characteristic of ADHD is a lot of trouble with sleep or staying asleep or both. Depression and anxiety. Depression in children, and even in some adults, but especially in children, depression symptoms look a lot like irritability and inattention. So if I have a child that's lashing out all the time, very reactive, a lot of times parents go, there's 0 to 60 and over nothing, that could be depression. And the same with anxiety. So children don't really know or understand feelings, they just feel it and they react. So those are some pretty common diagnoses that can be confused with ADHD, and any decent assessment or assessor will know that and look out for those signs. Next slide. Any questions about that autism piece? I'm sorry, the ADHD piece. Okay. Autism spectrum disorder. That is that's the description from the DSM. So it's persistent deficits in social communication, social interaction across multiple contexts. So that's similar to what we're talking about with ADHD. It can't just be like in one area, as manifested by following currently or by history. Then I don't know if I get into this in the later slides, but right now it's just the autism spectrum disorder, right? So we used to have autism and then we used to have Asperger's, and that has been combined to just say, this child is on the spectrum of autism. The early signs of autism should be picked up by the child's pediatrician, because that is who's seeing the child most. outside of the family. That is the most often professional contact that they are hitting. They're specifically screened at 18 months for autism and 24 months. Some common concerns that parents say, whether they're concerned about autism or they're just concerned about their child not realizing it may be autism, is the child's not responding to their name. They're nonverbal or very delayed speech. We're talking very delayed. My oldest son was pretty delayed in his speech, and I'll talk about him a little bit later because he probably has some learning disabilities or disorders, but he does not have autism. So again, keep in mind this, you have to take everything into context. Someone with autism could have very delayed speech. They may not. Some children actually can speak on schedule, and then they might regress a little bit. So that's the nonverbal piece. Regressive social or developmental skills, similar to what I just said. They may be hitting those milestones in appropriate time frame, and then they won't look anybody in the eye anymore. Maybe they used to respond to their name, but they don't anymore. Extreme behaviors, this can be tricky because they're children. Anger, tantrums, slapping themselves, that's pretty common, especially in the head, sometimes in the chest. So we've all seen children have tantrums, and they will all do this to some extent. But again, these are concerns that if it's happening often and over again and you can't get it to stop, so definitely bring up to your pediatrician. And then repetitive movements. There's a lot of rocking, a lot of flapping of the hands like this. Those are common signs. Again, if your kid does it, that does not mean that they have autism. These concerns should result in further screening and then a referral made for a comprehensive assessment if that screening shows up any further concerns. These characteristics alone does not mean that a child has autism. When I was recently out of grad school, I had a parent that was convinced that her child had autism because he liked to walk on the tips of his toes. And she had read, I believe it was Dr. Google had told her that that is a sign of autism. And so we want to be sympathetic to parents that, that's their child. And of course, they're like, any little thing that goes wrong, they're worried. But autism is, like I said, it's not just going to be one thing. You really need a spectrum of things over a period of time. And as we go on and discuss, you can see that sometimes the process of getting autism diagnosed can be very frustrating and hard for the family. Next slide. Someone that's going to diagnose autism, they need to be specialized. It's not like an ADHD. Oh yeah, I've done a training and I can do it. It's not that straightforward. It needs to be done by a qualified autism evaluator, and it's going to be typically a series of evaluations. It can be done in one appointment. I know of professionals that do that, but it is best to do it over time. It should be inclusive of the child's pre-health and behavioral health records and school records if they're school age. And it should be a comprehensive series of evaluations. Even if they're going to do it over a span of one appointment over several hours, there shouldn't be just like one thing they're filling out. It's really it's a serious diagnosis. So it's a comprehensive and serious assessment and evaluation. The common evaluation tools for autism. Here it's the Autism Diagnostic Observation Schedule. It's for toddlers and it's play-based, 2.5 years old, and can include more conversation according to the child's language level. There's communication and symbolic behavior scales. Next slide. Ooh, thought I had more on that. Go back one slide, please. I thought there was more on that, but really there's the difference between screening and evaluation. So remember when we're talking about that ASQ3, that would really be a screening. The actual evaluation is what we're talking about here, and that's going to be much more comprehensive. So a screening, you have, and I believe in a slide somewhere we kind of outline this, but you have a concern, and you discuss it with the pediatrician, then you get screened. And if there's more concerns or positive screening, then you want that full comprehensive evaluation. Okay, we can go to the next slide. So due to autism's unique expression for each child, the correct diagnosis can be difficult, and it's a frustrating experience for the family. It could take years to get an autism diagnosis. Many practitioners are not going to want to give a 5-year-old that may or may not be on the autism spectrum an autism diagnosis right away. There are other things to explore, other things to do, because you don't want to make that diagnosis in error. So a lot of the common diagnoses that they may go through first: ADHD, language disorders, speech disorders, sensory disorders, and behavioral disorder. Children that are high functioning on the spectrum, they can communicate, they do okay in school. Maybe they're, 7, 8, 9, and they're diagnosed with ODD or conduct disorder. And a lot of it could be misdiagnosed autism. So that's why it can be very frustrating. The family may think it's one thing and it's something else, and it can be really difficult. And if we talk about social determinants of health, I believe Waneke, one of our ACLA members, recently did a study regarding, the difference of Caucasian children getting diagnosed with autism and, the minority counterparts, Black children, Hispanic children specifically, and how their diagnosis is actually usually done quite later in life. And that's probably something I could start incorporating in this presentation. I don't want to give you any false data, but, the access to healthcare, but then even, system bias, practitioner bias, taking what parents are saying seriously. It can be different, depending on what your race is, what your experience is, how you're viewed. So that's something to keep in mind too, as, now you have an older kid who's still not diagnosed with autism, perhaps some social determinants of health could be looked at, parent education, and of course, access to healthcare, even access to resources or knowledge of resources. AmeriHealth specifically has a lot of great, wonderful programs, but do our members know? And that's one of our big pushes at AmeriHealth is, letting our members know what we have. The Medicaid population as a whole can sometimes be difficult to reach and difficult to educate on the different resources that are available to them. So keep in mind that equality and access to care will also play a big role. And as a child gets older and maybe they're right on the cusp, high functioning autism, that's going to be harder to diagnose than someone that's much younger, because they're going to be seen as this oppositional defiant and this conduct disorder. So it is going to be more difficult for that family and that person, that child. Next slide. So this is the screening flow chart, and this is kind of what I was talking to before. We want the parent to, they complete the screening tool in the waiting room, that ASQ3 or another screening tool, and the doctor will look at it, or the nurse, and they screen negative and the parent has some concerns. The doctor shouldn't just ignore those concerns, or the medical staff or the clinician shouldn't ignore those concerns. It should be further discussed, further explored, even if you're tabling it and making a note for the next visit. Even if you're sending them to a referral, maybe, okay, well, you screened, you're fine, but you still have these concerns. Let me refer you to this person. Maybe it's a behavioral health support. Maybe it's someone that specializes in ADHD or autism, just to give that parent the peace of mind. And in talking about social determinants of health and system bias, practitioner bias, how often is that being offered to people of color? To, if I have, a white parent, a Hispanic parent, or a Black parent, we want to make sure that they're all getting equal access. Is that done across the system? And I think that's where a lot of times it's easy for the practitioner to ignore is when like, oh, well, they screened fine, don't worry about it. But the parent has some valid concerns, right? And the practitioner, oh, that's just parenting. Okay. Oh, that's just nutrition. So while we don't want to overdiagnose, we also don't want to ignore concerns, even if the screening came out negative. If screen's positive, those steps are a little more clear cut. I think it's when it's not so definitive that it becomes a real struggle. So it outlines the steps and what should happen. But I really like to take the time to say that even if your screening is negative, meaning there was nothing outstanding, the concern of the parent should absolutely still be addressed. And even if you're not going to send them through an entire process of an autism diagnosis, there are still different referrals and resources that you could provide that parent to kind of give them the support that they need, whether it's parenting skills, whether it's just some education. There should be other things besides telling the parent, just don't worry about it and moving on. Next slide. Schools. So a pediatrician, right? They see our children, especially in those early years. And then the other big point of contact for a kid is going to be the schools, right? So we got the doctors and we got the schools. Those are the two biggest things in a child's life, other than the actual family system, that child's going to hit up. So let's see what schools role is in developmental screening. So we have public schools and private schools. I know it's not on the slide. A public school is mandated to do certain things by the state. A private school is not. I'm not saying private schools do not do things or have to adhere to things, but it is a different set of statutes and rules that they have to follow. So this is discussing public schools. I don't know a lot about the private school systems. Several screenings are done when they hit that kindergarten class, and in some pre-K classes as well. Some public schools will offer public pre-K 4, I believe. So for the earlier grades, they definitely want to catch, those learning disorders, difficulty with comprehension. They want to monitor those on grade level learning. They do a lot of assessments. I think DIBELS, I don't remember what that stands for, is a big one for Louisiana State. There's a lot of monitoring that they should be sending home to the parents regarding how they're doing earlier in the year, where they should be mid-year, where they should be at the end of the year, and then each throughout the year, where that child is stacking up. And they should be putting measures in place to accommodate the students that aren't hitting those milestones. And sometimes that can be a bit of a source of contention. Sometimes schools don't always do that to maybe a parent's satisfaction. And that could be possibly another area of discussion for, equality, social determinants of health, and access to care. There are screenings completed for reading and ELA comprehension, especially heavy in kindergarten and first grade and second grade. There are, I believe you have to be 8 years old or in second grade, but they will test you for dysgraphia, which is the writing, you having difficulty with your writing, dyslexia, which is the letters, and dyscalculia, which is confusing math and numbers-based information. Speech development, they will monitor for that, and vision and hearing. So similarly to the assessments and the screenings, just because your child is struggling in one area or another doesn't mean, the worst possible, or I should say the most extreme diagnosis. I have young one, my daughter is in kindergarten and she still talks like this. And it's very cute, but I don't think she's going to need speech therapy. She's just kind of, it's cute. She'll grow out of it. She's learning her letters. She now says L like L because she was before saying L. So, there's like just normal, cute little kid things that aren't no reason for alarm. If she did need speech therapy, if she still had trouble with her R's when I was a child, I think I still have trouble with my R's. I just blame it on my New York accent. I'm like, well, I'm a Yankee, so my R's come out weird. But even as a child, I had trouble with R. Came out all, no matter how hard I tried. And I don't have a learning disorder. I don't have ADHD. I don't have autism. So a kid can struggle with something for a significant amount of time, and it still doesn't mean that they have these diagnoses. So that's what those screenings are for. And the school is responsible to let you know your options. My kid's kindergarten teacher said, hey, we might want to put her into speech therapy at the end of this year, beginning of next year, because they're screening her. They're going to see how she does at the end of this year. So there should be parent-teacher conferences. The school has a responsibility to make sure that your child are hitting milestones, and then what they're going to do about those screenings and milestones if they're not hit. Next slide. 504 versus IEP. As a counselor, as a community-based worker, as a therapist, I was asked probably about this the most in working. If you've worked any amount with children, this comes up a lot. 504 is required by schools for children that have particular diagnoses to accommodate them, to make sure that they have the same chance of success as anybody else, any other child in that school. It's often called an individual accommodation plan, an IAP. I prefer to call it a 504 because it gets easily confused with an IEP. So the 504, the child needs the same educational access and chance of success as their mainstream counterparts. A lot of times it is additional time to take a test, ability to leave the classroom. Sometimes in certain situations, and depending on the school, certain kids can go into like a smaller group classroom to take a test. It can be different ways of seating arrangements. They're different. There's all different types of things you can do for 504s. And of course, schools do provide speech therapy and occupational therapy during school hours. School districts are different. That is actually another big social determinants of health and equal access conversation, which school districts and which school have the good stuff. So that is definitely a topic for discussion. An IEP is typically more geared towards behavior. So yes, the behavioral component is designed to track measurable annual goals for the child. Both of these are supposed to be developed with the school professionals and the parents and anybody else involved, like a counselor, a therapist, a social worker, hopefully not DCFS, but those types of like professional contacts in the child's life. And it has to address the social as well as academic accommodations. They have to be renewed annually. And if the school does not follow the 504 and the IEP, then they cannot suspend your child or expel your child. And again, that gets into some politics and some schools worried about their scoring and kids being labeled bad, or families or parents being labeled bad. So schools are required to do these things to provide those accommodations. And if things are not going according to plan is what they should be doing, there's always the school boards as well. Next slide. So there are different community resources if your child is struggling, or you think your child is having difficulties, ADHD, autism type of symptoms, and schools are required to provide resources and assistance. They usually contract out to individual vendors. I know way back when a lot of Baton Rouge schools used some vendor called People's Appraisal, and they did a lot of the ADHD assessments, and they did some screenings, not the assessments, but some screenings for autism, did a lot of the learning disability screenings and evaluations. So the resources are there. And if you feel like the individual school is not doing what they should, school boards are a great source of information and resources that should be accessible to any parent. Next slide. So these are the different sources and references I use for information throughout the article or throughout the slide deck. Are there any questions, any points of clarification?